So I've been at UAB now for almost 10 years, and I do open vascular and interventional stuff, and I'm going to talk about intracerebral hemorrhage, new developments. Is there a down button?
There's an arrow there, and this needs to be a little higher there.
Okay. My only disclosures are I get funding for participating in the Clear 3 and Misty 3 trials. But before I get into what I have to talk about, I just want to make a commercial plug briefly. This is us taking out a subdural hematoma. You can see the dura reflected up there. And probably the most common question I get from patients and their families afterward is, how do you keep the dura clean? And the answer is, Dura Wipes Extra. I have nothing but good things to say about this. You can use them to clean your garage. They're just as effective in the garage as in the OR. So today we'll talk briefly about the background of management of intracerebral hemorrhage. I'll talk about the latest version of the AHA guidelines and what I thought were the 6 key points in the latest version that came out 3 years ago. We'll talk about the INTERACT-2 and ATTACH-2 trials, which look at blood pressure management in intracerebral hemorrhage, the STITCH trials, which looked at craniotomy, and then the Misty trials, and then the CLEAR trials, which are ongoing for management of patients with intraventricular hemorrhage. So intracerebral hemorrhage is very common in society. It's responsible for 15 to 20% of all strokes. That's more than 1 million cases per year in this country. The median 1-month case fatality is 40%, and the chance of functional independence is less than 40% for most patients. Leading causes: cardiac hypertension, amyloid angiopathy. I think we've all seen plenty of patients with this problem. So ICH volume estimation. There's a technique called the A times B times C divided by 2 technique, which is remarkably accurate and reproducible. I think first published by Joe Broderick a number of years ago, but validated in a number of studies. And so to estimate the volume of a clot, you just measure the dimensions in centimeters. So this is 5.6 by 3.4 centimeters. And multiply that times the height of the clot, and then divide by 2. For this particular patient, we've got 37 mLs roughly. That's pretty accurate. So this is a landmark study that was published 20 years ago in stroke. Joe Broderick at University of Cincinnati. A simple retrospective study of 188 patients with intracerebral hemorrhage. They looked at independent predictors of 30-day mortality, and they found that volume was the strongest predictor of mortality in these patients. That patients with a volume of greater than 60 mLs and a GCS of 8 or less had a greater than 90% chance of dying, whereas if the volume was less than 30 mLs and they had a favorable GCS, they only had a 19% chance of dying. And so this is where this neurosurgical convention of considering surgery for clots that exceed about 30 mLs in volume comes from, this landmark retrospective trial from Cincinnati. And this is a chart from that trial. Oxford Handicap Scale is virtually identical to the modified Rankin Scale score. This is versus volume. And if you look at patients that came out of it with a favorable outcome, none of them had greater than 30 mLs volume of clot. And the patients with a high volume tended to have worse outcomes. Also, not just the mass effect of the clot is an issue, but also edema. It's called secondary brain injury. There's a wave of perihemorrhagic edema that occurs after a hemorrhage. In this patient, you can see the edema sort of surrounding the clot. My former mentor when I was a neurosurgery resident, Dr. Hoff at University of Michigan's Legacy, was demonstrating that this wave of edema comes from leaching out of thrombin from the clot as the clot contracts and then dissolves in the brain. So we'll talk about the latest guidelines. The first guidelines came out in 1999, the second in 2007, the most recent in 2010. And I just called what I felt were 6 key points from the latest iteration of the guidelines for management of intracerebral hemorrhage. First one is about imaging. They said consider CTA or contrast-enhanced MRI or CT to identify patients at risk for clot expansion. In the last few years, a lot of attention has been paid to the so-called spot sign. This is a patient with intracerebral hemorrhage. They did a CTA. This is the source images showing a small amount of extravasation within the clot. This patient went on to have a much larger expansion of the clot. The second point is patients with coagulopathy. Patients with some form of coagulopathy, most often due to taking oral anticoagulants, comprise about 8% of all patients with intracerebral hemorrhage. It's an ongoing problem for us. Patients with severe coagulopathy should receive appropriate factor replacement therapy or platelet transfusions. That's nothing new. But in these guidelines, they commented that prothrombin complex concentrates, or PCCs, have not showed improved outcomes compared with fresh frozen plasma, but may have fewer complications compared to FFP and are a reasonable alternative to FFP. Keep in mind that these are very expensive drugs. Co9, Novo7, various forms of PCCs are notoriously expensive, like cost about $8,000 a dose at our hospital. Interestingly, they also mentioned that platelet transfusion in intracerebral hemorrhage patients on antiplatelet agents is considered investigational. And as you know, this is becoming more and more of a problem when more and more patients show up with bleeding on dual antiplatelet therapy because of stents or whatever. Blood pressure management. The latest guidelines from 3 years ago said in patients presenting with a systolic blood pressure of 150 to 220 millimeters of mercury, acute lowering of the systolic blood pressure to 140 is probably safe. More recent data has come to light. We'll explore this further when we talk about the INTERACT study. Seizures and anti-epileptic drugs. Clinical seizures should be treated with anti-epileptic drugs. I think that's standard. But prophylactic anticonvulsant medication should not be used. They cited 2 studies of prophylactic use of Dilantin for patients with intracerebral hemorrhage where the patients receiving the Dilantin did not do as well as the patients not getting it. I think a lot of people these days are using Keppra because it's a lower side effect drug, and I'm not aware that that's yet been studied in this particular setting. I don't usually give prophylactic anticonvulsants myself in my practice. Intraventricular hemorrhage, they commented that intraventricular administration of TPA is still considered investigational. We'll talk about the CLEAR trial, which is actually looking at that, and the results will be released not long from now. And then the last key point is surgical treatment of ICH. For most patients with intracerebral hemorrhage, the usefulness of surgery is uncertain. And we'll talk about that in depth in just a few minutes. There are exceptions, though. Cerebellar hemorrhage in patients who are deteriorating, suboccipital craniotomy and evacuation of the hemorrhage is indicated. Initial treatment with ventriculostomy alone is not recommended, something I have to remind our residents. Lobar clots greater than 30 mLs and within 1 centimeter of the surface of the cortex, evacuation by craniotomy might be considered. We'll talk about the STITCH trial shortly. And minimally invasive clot evacuation is still considered investigational. So blood pressure management. Systolic blood pressure greater than 140 millimeters of mercury is present in some 3/4 of patients presenting with ICH. Elevated blood pressure at admission is associated with higher mortality among ICH patients. Expansion of the clot occurs in about 1/5 of patients. And AHA guidelines suggest target of a mean arterial pressure less than 110 millimeters of mercury, or systolic blood pressure, or blood pressure less than 160/90. This may strike you as commonsensical, but keep in mind that the current argument against aggressive blood pressure control in the acute phase after intracerebral hemorrhage is that a lot of these patients are chronic hypertensives and presumably may have a autoregulatory curve shifted to the right and may not tolerate aggressive blood pressure management in the acute phase. So the INTERACT trial was done. This is a study of 400 patients within 6 hours of intracerebral hemorrhage randomized to either intensive treatment of the systolic blood pressure to get it below 140 or guideline-based treatment to get it below 180. The endpoints were hematoma volume and edema. And there was a significant improvement in patients receiving intensive care versus the guideline-based care at 24 hours in terms of increase in hematoma volume with a p-value of 0.004, I think, and at 72 hours as well. In terms of edema, however, there is a trend toward a benefit with intensive care. So this is the first INTERACT trial. The second INTERACT trial was done with 2,800 patients, INTERACT 2, with spontaneous cerebral hemorrhage within 6 hours and elevated blood pressure. They were randomized to either target systolic blood pressure of less than 140 to be gotten there within an hour, or systolic blood pressure less than 180, the so-called guidelines management. Primary outcome measure was death and major disability. And they also had pre-specified modified Rankin scale score scheme to control for age of the patient. So INTERACT 2, the baseline hematoma volume in both groups was about 11 mLs. Time from ICH to actual treatment was 4 to 4.5 hours in the two groups. And the results are here. So the primary outcome measure was death or major disability. There was a trend toward a significant difference in favor of intensive blood pressure lowering, But when the outcomes were analyzed by modified Rankin scale score, there was a significant difference favoring intensive blood pressure lowering. So there are a couple of caveats with this study. One is that more than 2/3 of the patients were from China. It's well established that people in China seem to have a different natural history when it comes to intracerebral hemorrhage and so forth. And also, most commonly used antihypertensive agent in this trial was urapidil, which is a drug that's not available in the US. So the North American answer to that trial is the ATTACH-2 trial, which is being run by Adnan Qureshi, who's a stroke neurologist at the University of Minnesota. This is an NIH-sponsored, randomized controlled trial. Nicardipine is currently the sole antihypertensive agent being used. Treatment window is less than 4.5 hours after the intracerebral hemorrhage, and the treatment arms are standard management, maintaining blood pressure below 180, or intensive management less than 140, which is identical to the INTERACT trial. Primary endpoint is modified Rankin scale score at 90 days. And when I checked their website the other day, they had enrolled 406 patients out of about 1,200 planned, so it looks like they're about a third of the way through their trial, and UAB is actually a center in that trial. So let's consider craniotomy for ICH. This is an example of a craniotomy procedure. So the use of surgery to evacuate intracerebral hemorrhage was studied probably best and first in the STITCH trial, which was done back in the 90s, mostly in the early 2000s. 1,033 patients with ICH were randomized to early surgery or initial conservative treatment, 530 patients. And in that trial, the ICH volume ranged from 20 mLs to 63 mLs. 40% were lobar and 42% were in the basal ganglion thalamic region. Primary endpoint was favorable outcome at 6 months. And the bottom line was that the favorable outcome rate in the early surgery group was 26%, and the favorable outcome rate in the initial conservative management group was only 24%. And so if you look at their results by factor, and so this is an odds ratio graph where on the left favors surgery, on the right favors conservative management. The one that stood out the most was the depth from the cortical surface. So you'll see this box kind of on the left for clots less than 1 centimeter from the cortical surface. And so this led the investigators to wonder if perhaps limiting surgery to clots close to the cortical surface would actually lead to a better result for surgery. And that led to STITCH-2. So STITCH-2 was only published this year in Lancet. To be in STITCH-2, patients had to be conscious. They had to have a superficial lobar intraparenchymal or intracerebral hemorrhage of 10 to 100 mLs in volume, no intraventricular hemorrhage, admitted within 48 hours of the ictus, and the primary endpoint was favorable outcome at 6 months. And they also did an outcome analysis to control for age. So a total of 601 patients with superficial ICH were randomized to early surgery or conservative treatment, 307 versus 294. The mean intracerebral volume, hemorrhage volume was 40 mLs, mean depth was only 1 millimeter from the cortex. And the favorable outcome rate at 6 months for early surgery was 41%, and for initial conservative management was 38%. This is an analysis on intention to treat. There were 21%, I think, of the conservative management patients, or the initial conservative management patients actually crossed over, but this is intention to treat. So conclusion 1 of 2 from that trial was no significant change in mortality or disability rate between the two arms. However, and that's supported if you look at the details. If you look at the Kaplan-Meier curves, there might be a slight survival advantage for early surgery. So the red is early surgery, the blue is initial conservative management, and the p-value is 0.073. So based on this Kaplan-Meier analysis, there was actually a trend toward a significant advantage for early surgery. So let's talk about minimally invasive intracerebral hemorrhage evacuation. There's generally 3 techniques for this. One is stereotactic image-guided placement of a catheter within the hemorrhage. And so this is a patient with a burr hole, a catheter, fairly large bore. It's actually larger compared to a ventriculostomy catheter with fenestrations near the tip is placed within the clot, and then you can drain it, or you can do that surgery plus infuse TPA directly into the clot, or you can use an endoscope to go in and evacuate the hemorrhage, which is a project that's been undertaken by Neil Martin at UCLA over the last several years. So minimally invasive surgery plus recombinant TPA for ICH extraction, which is the Misty Trial. The Misty 1 and 2 trials were NIH-sponsored phase 1 and phase 2 safety and efficacy trials. Now is starting the Misty 3 trial that we just had the nationwide investigator meeting for just last month. So Misty 1 and 2 were meant to determine dose and also safety. So the phase 1 trial randomized people between a third or 0.3 milligrams of TPA every 8 hours after minimally invasive surgery to place the catheter in the clot, or 1 milligram every 8 hours. ISIS is this endoscopic evacuation sub-study of the trial. And then the phase 2 trial, this is 60 patients. Phase 2 trial was 50 patients, medically treated or with image-guided placement of a catheter, and then 1 milligram of TPA every 8 hours. At UAB, we participated in Misty 2 and enrolled 2 patients right at the tail end of their trial. So this is a patient that we've treated with thalamic or basal ganglia hemorrhage. The catheter was placed. We gave TPA, 1 milligram every 8 hours into the clot, and the clot got smaller over 3 days. The midline shift improved. Whether this helps patients in the long run is not yet clear. However, there are encouraging results. So the data from the safety trials, the Misty 1 and 2 basically, was that the procedure is relatively safe. And so these are all of the patients for the entire trial. They all fell below the pre-specified thresholds for stopping the trial in terms of mortality, infection, and symptomatic bleeding. So this is regarded as showing that the procedure is relatively safe. And the surgery also resulted in faster clearing of the clot compared to medical therapy. And so this is medical patients, days from the initial CT, volume of hemorrhage, and this is patients treated with surgery and the TPA. You can see that they just had a faster decrease in the volume of the clot. So does this help patients, however? So this is that same graph that I showed earlier from the Cincinnati study from 1993, showing that patients with larger volumes of clot tend to cluster in the worse off outcome groups. But in the Misty 2 trial, a lot of the patients treated with surgery wound up with relatively good outcomes. And this is really striking for us because this is powered to determine safety, not efficacy. And so Dan Hanley, the PI of Misty, presented this at the stroke meeting in Hawaii last February. And it turns out that the patients treated with surgery had actually better outcomes at 6 and 12 months as well in terms of modified Rankin Scale score. And so this is the 1-year outcome rate, modified Rankin Scale score, surgery versus medical therapy. And you can see that the upper groups, in terms of favorable outcome, were greater than the medical group, and this is statistically significant. So the Misty 3 trial has been planned and funded. It's a phase 3, 500 subject trial. Well, 70 some centers internationally, UAB is one of them. Patients with spontaneous supinatory intracerebral hemorrhage of 30 mLs or greater will be enrolled, randomized to either surgery plus TPA, 1 milligram every 8 hours, to a total of 9 doses, or medical management only. Primary endpoint is modified Rankin Scale score at 6 months. And we hope to begin enrolling patients here at UAB this coming spring after we get through grants and contracts and IRB and all that kind of stuff. So let's consider intraventricular hemorrhage. Intraventricular hemorrhage occurs in some 45% of patients with intracerebral hemorrhage. You can have pure spontaneous intraventricular hemorrhage as well, but it's relatively uncommon. This can cause obstruction of CSF drainage and hydrocephalus and is a significant source of morbidity. So the CLEAR IVH trial was to determine if infusion of TPA into the ventricles would actually benefit patients. And so the CLEAR IVH trial was a phase 2 safety, dose finding and safety trial that we also participated in when Anissa Delt was here. And The Clear IVH phase 2 trial enrolled 48 patients. They all required ventriculostomy as part of the standard care of their management. And then they're randomized to either placebo, which is saline, or saline plus TPA 3 milligrams every 8 hours. And this is from the paper in Stroke in 2011, and none of the groups, none of the patients met the pre-specified safety thresholds for stopping the trial, which was 30% infection, 35% bleeding or rebleeding, and 75% death. However, there was a suspicion that there was a greater rate of symptomatic bleeding in the TPA group compared to the non-TPA group, 23% versus 5%. P-value for this is 0.11. So it's not quite a trend, but it is kind of concerning. And so when we saw this, we thought, you know, is 3 milligrams every 8 hours really safe? And so the Clear, but on the other hand, the clots resolved a lot more quickly with TPA versus placebo. So the phase 3 version of Clear is actually organized to give 1 milligram of TPA every 8 hours instead of 3, in hopes that that'll have a less significant rebleed rate. So Clear 3, also run by Dan Hanley, the PI of Misty, NIH-sponsored randomized multi-centered trial of TPA in saline or saline only every 8 hours. It's blinded. Planned enrollment is 500 patients study-wide. Presently, they have exactly 400 as of last weekend. At UAB, we have enrolled 10 patients so far, and we've had fairly good results. Of the 10 patients we've had one extension of the intraventricular hemorrhage, but we don't know if that patient got saline or TPA. We expect the enrollment to be completed in this coming year, and probably the trial results to be published in 2015. So that's all I have to say. Do I have any questions?